Stronger by probability or stronger by this utility?
Stronger by estimated precisions and some statistics.
So anecdotally, the first time I heard the phrase grant student was from some of Milos's students back at I think a AAAI meeting. These two guys that I didn't know came up to me and introduced themselves as my grant students. They were PhD students of Milos. So thank you.
Thank you, yeah. Any other questions?
Hello, good afternoon. I'm Leong. I'm from Singapore. Pete was my master's and PhD thesis supervisor and lifelong mentor. I actually joined MetG in 1984, and I was a student of Bill Long's, and I did a Europe project with him, and then that led to my bachelor's thesis. This was the first paper that I published while I was in MetG, and it was in SCAMC. It was an expert system that detected abnormalities related to different heart sounds, and it was an exciting project because it was to translate all the information from the textbook into the system, and actually one of the colleagues then, Tom Russ, helped me took all these pictures and put onto the system on the list machine, and it was very exciting. And I got to present the results at the first conference. That was it. That was 35 years ago when I was introduced into MetG. So since then, many things have happened, but one thing that I have been doing over the years and also continue to do is that the work on AI in medicine very much motivated by the first work by Ledley and Lusted, looking at how to build models to improve the accuracy of decision making, to help the doctors to make better, more accurate decisions to diagnose diseases, to lead to better, more effective treatments and better outcomes, and reduce medical errors. And so this was 60 years ago, that the seminal work of Ledley and Lusted, and many of the scientific questions and the technical challenges, I think, remain today in all the work that we are trying to do. So over the years, after my, this was, well, I think Mike showed this picture earlier than me. There was another one. It was in one of the AI in medicine workshop at Stanford, I think. Okay, and it was we all happy bunches. If you see, you realize that there's something that doesn't change. All the pictures that are shown over across different generations of students, we all look very happy. Right? I graduated in 1994, and I went back to Singapore and became a faculty member in the National University of Singapore, and I built a research group trying to model after MetG, and I called my lab a medical computing lab. It was in 1995, and I first started a collaboration with the doctors in Singapore, building machine learning models and decision support models. And these were my groups in the early 2000s. And Pete actually visited us in 2000 and also gave us a lot of advice on how to set up a medical informatics program at that time, together with Ted Shortlift and also Otto Reichhoff at that point. So he has been a mentor and advisor since then. And this was my group a few days ago. After my the group meeting, I have 3 more students not in the pictures. They're still working on AI and medical decision making. So just a little bit of summary of what are the current work that we've been doing. My focus has always been on dynamic decision-making under uncertainty, looking at knowledge representation and planning and decision-making and control. And this is a recent work by one of my students who just graduated, and she just joined Mayo Clinic as a postdoc recently. It's looking at multi-view learning and multimodal fusion, and trying to make sense of the disease stages and also to predict the progression for dementia patients. Dementia is a neurodegenerative condition with no known etiology. The difficulty in trying to have accurate diagnosis is that because many of the biomarkers the symptoms show up late in the disease stage. Okay? And then there are different types with imaging, with the CSF proteins, and also with the behavioral estimators and all that. So what my student did was that we come up with a model that will learn the latent factors that's affecting all these potential symptoms and signs, and looking at probabilistic way and also incorporating some domain knowledge to come up with a model. And the data set that we have been using is the Alzheimer's disease neuro imaging initiative, the benchmark data, as well as some locally collected data in Singapore, looking at the dietary and also the behavioral aspects of the of population which are potentially would develop into the mild cognitive impairment and also Alzheimer's disease. The other aspect is looking at dementia from the social economic challenges perspective. Singapore is a rapidly aging society, and 1 in 10 people over 60 has dementia, some degree of the dementia. So this is a really serious problem, especially when the caretaker, the caregivers aging themselves. Okay, so there's a way of looking at what are the ways that technology will be able to help in taking care of the elderly patients and the elderly who are developing actually dementia. This line of work is on assistive care robotics, as more on transfer learning and reinforcement learning in dynamic environments, and looking at how perhaps we could build a robot that will be able to perform a series of tasks, for example, guiding the patient in certain settings with incorporating the patient model, means knowing the state that the patient is in, the cognitive capabilities in the states, and also to come up with reminders, alerts, communication with the caregivers, and also to actually come up with some ways to initiate reminiscent therapy or to try to calm the patient down. Okay. Some line of this work is on transfer learning, in planning and decision making, and also in hierarchical reinforcement learning. And some of the recent projects that our group is doing is on collaborative AI and also in temporal causal models. So these are some of the work that we have been doing in Singapore. We are also looking at another perspective, a larger perspectives on AI in medicine in Singapore in general. Singapore is a very small country. We have about 5 million people. We have 6 public universities and about 10, 20 research institutions that deal with computer science and AI in one way or the other. The problem is that there's so few people, and we're doing different types of work related to AI. And in recent years, there is also an emphasis on health informatics, but we do not have a formal training program in health informatics. So one of the recent initiative by the government is to how to actually we harness all the power and all the resources in AI, and also especially for application in different vertical domains with important social and economic impact in Singapore. So in recent year, we have started a national program. It's called AI Singapore. The mission for AI Singapore is to build a vibrant ecosystem by bringing together the AI talent, the AI technology, and also to build infrastructure and framework that will bring AI research all the way to translation into industry innovations. Okay? So not only just to support the fundamental research area, but also to see how we could expedite the translation into actually industry innovations, deployments, and commercialization. So you should not want to take 17 years, for example, to translate the research to practical use. But this is a big experiment. We do not know whether it's going to be successful or not, and we are actually just already putting into the resources to do this. It is supported by the National Research Foundation, which is a funding agency like NSF, and also many of the different government agencies to support the coordinate of the work. And our partners have all the public universities, public funded universities, 6 universities as partners of AI Singapore. So one of the programs of AI Singapore is to come up with AI Grand Challenge programs. What is the AI Grand Challenge? It's the important issues and problems faced by Singapore or the world, which can be effectively addressed by AI technologies and innovations. We try to identify a challenge problem as an inspiring problem. It's important, and everybody will realize the significance. It has to be impactful. It's going to affect many people, especially in Singapore. Okay? And somehow it has to be measurable. We want to see an endpoint where the investment and also the efforts and all the implementation that goes into this program will be useful at some point. So we're looking at defining challenge problems to set up the funding program and also to facilitate the process of making research all the way to practice. Such challenge problems were formulated by the AI and domain experts in the different categories. We have launched AI in healthcare AI Grand Challenge this year. Actually, the projects were funded this year. It was launched last year, and we're actually looking into education coming up. These challenge problems are guided also by thought leaders. It has to be aligned with national priorities because we need the government to support the infrastructures and all the other coordination. And hopefully it will lead to sectoral transformation. I just want to mention a little bit about the AI in Health Grand Challenge that we have just launched. It is a challenge problem that is aligned with the Sustainable Development Goal for the United Nations, which is to ensure wellness and health for all ages. And it has to do with how do we address the 3 top chronic diseases in Singapore related to the 3 highs, the high cholesterol, high blood pressure, and also diabetes. The top 3 causes of the polyclinic, which are the general practitioners, that's government funded attendance, and it has actually devastating potential complications that will lead into stroke, heart disease, renal, fatty kidney disease, and so on. If left unchecked, the amount of the disease burden and also the cost is probably about estimated to be about 4 billion Singapore dollars per year to manage that, okay, to project that. So the challenge statement is to come up with how do we have a system, AI systems that will help primary care teams to stop or slow disease progression and complication development in 3 highs related patients by 20% in 5 years, because it's aspirational goals. And in order to actually encourage and also to support participation, we have left the design of the measurement, for example, for the direct clinical outcomes, cost or surrogate endpoints to the teams who come up with the proposal to address the challenge. So this is a 5-year, 2-stage program. The first stage, we actually select 3 teams with the support of about $5 million each for 2 years. And then at the end of 2nd year, they will have a midterm evaluation, and one team will be selected to go on for the next 3 years to complete the challenge itself. Okay, it's a multidisciplinary private-public teams and consortia, usually led by an AI expert and with a clinical collaborator and a team of experts, and also including perhaps the behavioral psychologist and the community care teams and so on and so forth, to come up with a proposal to see how we will be able to address this challenge in different ways, and it also involves international collaboration as well. So we started the program in the third quarter of 2017, where we have ideation workshops to get people together to come up with ideas of how do we actually structure the challenge and what are importance. The launch was in June last year, actually, and then there was a series of workshops that get people together to form teams, and then a panel of evaluation was done by international review panel, and 3 teams were selected in March this year, and the project started in May. So we just started it, and at the end of next year, with the midterm evaluation, we'll start and then see how we will actually bring one team among the 3 to go to the second phase. So there were 3 teams. The 3 teams were all consisted of large consortia, maybe of 20 to 30 experts and PIs with clinicians and AI experts. The first team actually did a lot of research. They published in scientific venues like JAMA and other medical forums on retina therapy, and also the detection and also early treatment for that. And building on that technology, they have also come up with a range of facilities and also a range of proposals and services to see how they could assess the risk of the population, and also to customize the treatment to different target populations, and so on to come up with the solution. The second team is also led by the NUS and also the NUS National University Health Service Consortia, the clinical group. They built the solution, they proposed a solution based on a platform for data analysis and data support for clinical decision making that they have built over the last 10 years, actually, with the hospital group. And the third consortium, led by the faculty members from the Nanyang Technological University and another healthcare group in Singapore, based their solution on community-based care and programs, and also gamification of some of the technology that persuade and also coach change in health behavior. So some of the details will be available on the website. In essence, all the solutions that were proposed actually touch on many different aspects in the continuum of care, where AI technology can help make a solution. On a personal level, where health profiling and wellness maintenance are facilitated by the wearables, the environment, and wearables sensors, and also that supports communication with the caregivers and the clinicians. At the home and community side, monitoring, smart monitoring, reminding, and also assistive care robotics and decision support supported through consumer and social analytics to support the design and also management of community and also the home services for healthcare. And on the other side of the spectrum, in the primary care and also hospitals, AI technology is used in helping the diagnosis, treatment, and prognostic management through predictive modeling, data analytics for risk stratification, progression detection, and also the design of personalized care plans and workflow processes. Okay? Some of the solutions also incorporate methods to support scientific discovery, for example, the drug discovery, and also the public policy formulation. So of course, what we have seen that if we really want to support such challenge programs to actually realize the objective of bringing research all the way to translation, we need to support, we need to come up with some facilities and also some processes that will allow some of the practical implementation challenges or hurdles to be solved. So AI Singapore, as a facilitator, we also work very closely with the Ministry of Health, especially the Office of Health Transformation, to make sure that the proposals for the challenge and also how we're going to structure the challenge will actually tie into their plans on the 5-year plans on transforming primary care in Singapore. So some of the solutions and some of the practices and procedures have to be in line with what they're doing. And that's why, and they're also putting in resources and manpower to guide the implementation and development of some of these solutions. And the AI in Health Grand Challenge also fits into the National AI Strategy on healthcare, and is going to be one of the main use cases for the Singapore National AI Strategy. So that some of the departments, across departments, will be able to help, for example, to support access to data. And of course, we know healthcare data is the most important part when we actually to build any of these solutions. And we work very closely with the Ministry of Health, with the data custodian, and we have to build some data vaults, secure system and secure physical facilities to allow the researchers to get access to the national electronic health record data. Those are in the process and being done. And beyond that, we also have to put in place the IP and technology access model so that there's very clear process and understanding of how the IP issues can be resolved right from the beginning, so that we have a lot of the negotiations down the line, and looking at AI engineering to support the translation research as well. So the AI Grand Challenge program is unique in the sense that it combines research, development, innovation, also training of PhD students, training of engineering talent, and also the private-public partnership, because at the start of the second phase, we're actually bringing in industry partners and also the entrepreneurs, the big companies, to make sure that they will be involving in some of the projects, and especially the second stage project, and to actually implement and bring some of the solutions into market and practical use. So this is a big challenge itself. Running the challenge is a big challenge itself. It's still experimental. We hope that it will be successful. We are still learning a lot of the things that we're doing, putting in place, and that we do not know whether what are the uncertainties, and also what are the hurdles that we need to resolve in order to make it a success. But we are trying. We hope that this will be something, a new experiment, a new way of actually bringing the AI in medicine understanding and results into practical use in a systematic and also in a practical manner. So this is what we have been doing, and in order to make it successful, we also have to have the other part of the governance, of the regulatory part in place, and then this is also in progress. Okay, AI Singapore and also working with the Singapore AI government, the Singapore AI governance framework is looking into the different ways of when we actually put all these solutions into use. What are the policy? What are the guidelines? What are the processes have to be put in place so that in terms of ethics, in terms of governance, in terms of regulation, everything will be there when the solutions are ready to be put into practical use in about 5 years' time. Okay, so in that, we are also participating in some of the international forum to actually help us form some of the plans and the practice. So these are some of the things that I've been working on, and also where our group and also people in Singapore have been working on in AI in medicine. And many of these things actually have to thank Pete for the not only to teach us about the technical side of the knowledge, but also we learn from you very much how to work with people, or what are the things that we need to think about, and it's still a learning process for me at the moment. But I must say that as many of you have realized, that Pete has always been inspiring, very supportive, and also to encourage us to do things that, well, has never been done before. Okay, we will try. We always hope for the best, and this is some of things that I think Maggie has impact or his influence on the other side of the world. And thank you.
Yeah, you can.
Yeah, time for questions?
So was this driven by the government? Where was the
Yes.
initiative coming from?
Yes, it's a national program, so it's a funding program.
Okay.
Yes.
I think it's great that this work has been funded, and I guess I'm an optimist, but the pessimistic version of me would say, what, if anything, do we know about the problems of those chronic diseases that you articulated that makes them amenable to whatever AI, assuming that we had perfect omniscience of delivering the best that doctors know how to improve those conditions? What evidence do we have that would actually be impactful in the way that your government wants us to, and other governments want us to impact those chronic diseases?
Okay. When we formulated the challenge problems, there were actually, we came up with a set of 6 problems. Okay, this is one of them. The other one is dealing with dementia. How do we actually support dementia patients to make them extend the duration for independent living for 5 years? That is another challenge. And there are a couple of other challenges. And it actually has gone through a selection process from the domain experts, the doctors, not so much public, but it has to go through also the policymakers, and also from the Ministry of Health. And they feel that this is the challenge with the solutions that will make the most impact for them, that will help them most.
So I certainly see that anything that we would do in this area that would improve outcomes, quality of life in the near term by 10% even would be great. But do we have any evidence that we know how to do anything in that space? In other words, let's say, one bit of evidence would be doctors who behave exactly the way people say do much better than doctors who don't.
Well, I guess one of the in the feasibility studies phase that we have checked is, in some cases, for example, the referral for the eyes. Okay, if they have the quick detection that that somebody may have problems with the eyes, and then we'll be able to do a quick triage.
So it's more like improving process measures.
That's right. That is one of the examples. Okay, there could be other examples. So the teams have come up with a few areas, okay, on the impacting the lifestyle, perhaps, and also impacting the screening process for some of these cases. It could make a difference, but we do not have hard evidence that is definitely going to be 100% successful. Yes, you're right. We are all optimistic, but with careful optimistic that the doctors and the committee has looked at the problem and say that there could be ways that can help.